Good evening, everyone. Thank you for joining us today. Uh, we are here to explore how leveraging the comprehensive support and expertise behind ERA can help us optimize outcomes in reproductive medicine. I'm Vikram and I'm delighted to host this session. And before I get started, rather, we get started, Um, please bear us for another 5 minutes, more or less, in order to allow more attendees to join in who have already registered for this volume. So let's wait for another few minutes. Thank you very much for your patience. Sorry for this bit of delay in starting the webinar and handing over the session to the speaker. It's just that we are trying to, make sure that maximum of the registrants who have already registered for this webinar, they just join in so that everybody gets benefited, with today's topic. And just to refresh everybody here in the audience, uh, this is a yearly routine that we are following in order to keep all the doctors like you abreast with what are the latest developments, what are the publications, and talk about the protocol, talk about the optimization, or talk about the proven solution in RIF. So, this has been our endeavor. Last year also we had a series of ERA webinars. We had 3 volumes there, and this year also today is the third volume. Um, just to refresh you all, we had the first volume on 12th of April this year, and the topic was proven solution for RIF. Because this year we have a theme, like many a times we have like why ERA. So we are just trying to, focus on that topic. Why ERA? So on 12th April, we spoke on, Dr. Tiffany spoke on proven solutions for RIF. And then we had a second volume on 31st of May, wherein she explored the unmatched precision of ERA to further maximize patients' results. So today, which is the concluding volume of this series, we'll be talking about leveraging the comprehensive support and expertise. Very, very important. Both support and expertise behind ERA to optimize outcomes. Ultimately, the goal for all the doctors like you and we as a service provider, the goal remains the same. That is to optimize the outcomes. So I think we have increased in numbers, but please and please, humble request, you can understand how it is. Just let's wait for another 1 or 2 minutes more, just couple of minutes, and then we will go ahead in the interest of the registrants who are yet to join. Thank you. Thank you for your patience. So let's begin with the webinar. Today's volume is, as I already mentioned, leveraging the comprehensive support and expertise behind ERA to optimize the outcomes. So, welcome you all to this third volume of ERA series titled Why ERA. Thank you very much for joining us this evening. In the interest of the audience, I'm Vikram. I'll be the host of this session. And before we get started, I will just very quickly introduce our, known speaker who is quite known now in India. So she's based out of Florida, basically. And it's Dr. Tiffany Stankiewicz. And a very quick introduction for the benefit of the audience. Tiffany Stankiewicz earned her bachelor's degree in animal biosciences from the Pennsylvania State University and a doctorate in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling for both embryonic aneuploidy and endometrial receptivity using genetic testing. Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist and is certified by the American Board of Bioanalysts as a technical supervisor in both embryology as well andrology. In addition to clinical laboratory experience, Tiffany coordinated many aneuploidy and single gene cases as PGT director at a large IVF clinic in Philadelphia. Tiffany made the move to reproductive genetics in 2016 when she became the PGTL lab manager at iGenomics in New York lab. In 2017, her primary focus in the company shifted to endometrial testing when she took on the role of endometrial specialist, concentrating on ERA, EMMA, and ALICE tests. Today, Tiffany serves as the Global Endometrium Product Director for iGenomics. Furthermore, very quickly, Tiffany has published and presented research at conferences such as the Pre-Implantation Genetic Diagnosis International Society, which also know, as you all know, is also known as PGDIS. Then the American Society of Reproductive Medicine, that's ASRM, then ESHRE, and the Pacific Coast Reproductive Society. That's PCRS. Tiffany is an instructor at Eastern Virginia Medical School and is a member of the American Association of Bioanalysts, the College of Reproductive Biology too, and the American Society of Reproductive Medicine. This is about Tiffany. Now, before I hand over the session to Tiffany, I would just like to, request you all, esteemed doctors here, that, it's our endeavor that after every session, every webinar, we share the recording with you all. And still, if you want to know more about ERA, then we have this ERA Insight Hub in Vitrolife website. I'll put it in the chat, www.vitrolife.com. You can just visit that and search for ERA Insight Hub. You will get ample details out there. So, for your benefit, your patient's benefit. So, thank you very much for hearing me out here. And I hand over the session to Tiffany. Tiffany, all over to you. Thank you.
Thank you, Vikram. Thank you for the introduction, and thank you everyone for attending today. So as you know, today is our third volume of our Why ERA webinar series, and that's leveraging the comprehensive support and expertise behind ERA to optimize outcomes. If you recall in the introduction, I think one thing that exemplifies that, you could see I've served as an endometrial specialist for the past 8 years, where I focus just purely on endometrium. And we have a whole team of specialists around the world who are here to help improve ERA outcomes and maximize results for your patients. So today I want to share how we can do that. But before we start, let's do a quick introduction. Implantation is a significant rate-limiting step in both human reproduction and IVF. I think we're all aware of this. And quite simply, what is the equation for success? It's very simple. An optimal embryo plus an optimal endometrium. These are the two factors we need to focus on in order to optimize implantation. Now, when we define an optimal endometrium, what does this mean? Well, there are two main factors to consider. The first is receptivity, or timing of embryo transfer, and the second is the microbial health of the endometrium. Now, since we're talking about ERA today, we're going to be focusing on the receptivity factor. So let's start with discussing recurrent implantation failure. Recurrent implantation failure affects approximately 10% of couples undergoing IVF. And after the third failed cycle, 22 to 50% dropout rates have been reported, with increasing tendency with each consecutively failed cycle. Now, when you talk to patients who suffer from recurrent implantation failure, you can see they're desperate to do something different, to effectively address and overcome their implantation failures. They truly want a solution. Now, being that 1 in 3 women with RIF have a displaced window of implantation, how can we account for this and facilitate successful implantation in those cases? And that's where ERA comes in. So first introduced in 2011, ERA, or endometrial receptivity analysis, is the world's first molecular assay used to determine each woman's unique, personalized embryo transfer timing, therefore synchronizing the embryo transfer with the individualized window of implantation. Actually it's been 2 years now, the European Society of Reproductive Medicine and Embryology, or ESHRE, came out with their good practice recommendations on recurrent implantation failure. And you can see they recommend investigations for RIF, one of those investigations being endometrial functioning testing such as receptivity, for example ERA, can be considered in patients suffering with recurrent implantation failure. Now, ERA is the only endometrial receptivity test backed by a randomized controlled trial, and this was performed by an independent group and published in 2024. We have several resources regarding this RCT because the results are quite important. Here, the authors not only utilized ERA, but also in conjunction with PGTA, again, addressing the two main factors in order to achieve successful implantation. Now, briefly, there were three different groups in the study. The study group were advanced age patients, 35 years and older, who underwent PGTA plus ERA. Control group 1, which were also advanced age patients, except they only underwent PGTA testing at the standard time of transfer. And then control group 2, which were patients younger than 35 years old, who also underwent ERA plus PGTA. And what we found, or what the authors found, was that patients who used ERA had significantly higher pregnancy rate, implantation rate, and live birth rates, even when using euploid embryo transfer. So the conclusions made by the authors was that PET guided by ERA significantly improves pregnancy, implantation, and live birth rates. And with no significant difference between the advanced age patients who use PGTA plus ERA and the younger patients who use PGTA plus ERA, we see that ERA mitigates the effects of endometrial aging and normalizes the reproductive outcomes for patients of advanced maternal age. Now, how do we leverage the comprehensive support and expertise behind ERA in order to optimize your patient outcomes? Well, just to give you a bit of insight, we're backed by a global team of endometrial experts. ERA is a trusted endometrial receptivity test used by over 3,000 clinics worldwide. Our comprehensive support network includes world-class scientific advisors, dedicated endometrial specialists, genetic counselors, and in-house clinicians. We provide expert guidance not only to clinics, but also patients every step of their way. One important feature of ERA is cases are reviewed by our endometrial experts. So proper protocol compliance is key in order to have the best patient outcomes for ERA. Our unparalleled endometrial receptivity team reviews patient cycles and results to ensure the accuracy of their findings and the accuracy of the recommendations for personalized embryo transfers. We account for factors such as proper endogenous progesterone control and cycle protocol replication, thus providing the most precise results. And you've probably seen this just with our requisition form. We do ask some more details and maybe some other endometrial receptivity tests. But the reason for this is to ensure, again, the accuracy in order to provide the most precise results. And I'll give some examples of this. Now, perhaps you've had patients who have had multiple ERA cycles for whatever reason. Maybe they came back after several years and wanted to ensure that their window of implantation has not changed over that time period. Maybe they're trying a new cycle protocol, changing from HRT to natural, or maybe they're just changing their progesterone. Sometimes we see patients will repeat the ERA if they move amongst different clinics, again, just to retest to ensure where their window of implantation lies. So this is where the reviews of cycles to understand if results can be correlated or not, and potentially reveal special observations come in. So I take an actual example here. This patient had 4 mock cycles, and our team needs to understand, can we correlate the results? We simply do not just report our findings from one cycle and take that as the final result when we see that the patient has multiple biopsies that have been performed. So we ask information such as endometrial thickness. We know that endometrial thickness can affect the transcriptomic signature. So for instance, if a patient is always between 6 to 12 millimeters for all of her cycles, then we can correlate the results. However, if a patient one cycle has a lining of maybe 5.5 millimeters, and the next cycle their lining is 10.5 millimeters, then we know that the change in endometrial thickness may affect the reproducibility of our findings. So this is one aspect we look at. Obviously, control of endogenous progesterone is imperative. We want to make sure that the patient's not producing her own progesterone prior to the first intake and HRT cycle, since that first measurable amount of progesterone is going to initiate the transformation of the endometrium from non-receptive to receptive. So we have to ensure that we're getting the correct start time. We'll also look at things such as cycle protocol. And that's where, if you note here, we have a different cycle protocol that was used in mock cycle 4. Let me get my pointer here. So in cycle 1, cycle 2, and cycle 3, the patients took IM progesterone, 50 milligrams per mil, once a day. However, in the 4th cycle, they started the same IM progesterone once a day, but then on day 2 of progesterone supplementation, they then changed to twice a day. So this change in progesterone protocol meant that we could not correlate cycle number 4 to the previous cycles, and cycle number 4 needed to have the results interpret independently. If this is something that we didn't check, there was a potential that maybe the window of implantation was not accurately detected, or perhaps we missed a special observation such as a narrow window of implantation. So having a team to thoroughly review the patient's cycles to ensure precise reporting is absolutely necessary in order to optimize patient outcomes. Now let me give you an example here. This was one patient who came through while I was an endometrial specialist for North America, in which her cycles revealed special observation, which was an extremely narrow window of implantation. This patient was a 40-year-old woman with primary infertility and previous failed euploid transfer. She only had one embryo left. That was autologous. Unfortunately, when she would undergo fresh IVF cycles with PGTA, she would have a 0 to 1 embryo per cycle for PGTA testing. So her number of embryos available for transfer were quite limited. So she decided to undergo the ERA test. And because she switched from one clinic to the next, the ERA test was repeated a bit more than usual. But let me share with you her initial results. Her first biopsy was taken at 108 hours of progesterone exposure, in which a pre-receptive one-day result was obtained. The recommendation was to perform biopsy 24 hours later. At this time, at 24 hours later, at 131 hours, she was still pre-receptive one day. Now, this is a special observation we see. 89% of women with a pre-receptive one-day transcriptomic signature will reach receptivity with 24 hours more of progesterone exposure. However, there's still a small subset of about 11% of women who still won't reach receptivity with that 24 hours. Maybe they reach receptivity before because their window of implantation is quite narrow. Maybe they need additional progesterone exposure beyond 24 hours because their endometrium evolves slower than what we've seen with other patients and the controls within our test. And this is very important because this is precision medicine at its best. Every woman is unique, and every woman's window of implantation is going to be dependent upon her own genetics. When is she going to be receptive, but also how long it takes her to get to that receptivity. So even though 89% of women can achieve receptivity within 24 hours when they have that initial pre-receptive one-day result, that does not mean that every woman will. So in this case, we see that she had a slowly evolving endometrium. And we recommended, again, another biopsy 24 hours later at 156. At this time, it showed that she was in the transition phase between pre-receptivity and receptivity, and recommended transfer 12 hours later. Now, instead of undergoing transfer 12 hours later, the patient decided to undergo another biopsy, in which at 169 hours, she was found to be receptive. So exactly what we had anticipated. Now, at this time, she switched clinics and she went to a new clinic in which they performed a natural cycle in ERA number 5. But however, since she was performing a natural cycle and her previous cycles were HRT, we could not correlate the results. The natural cycle results needed to be interpreted independent of previous biopsies. With that said, they then end up going back to an HRT cycle and biopsying again at the 170 hour. So we've already found receptivity there at 169. So just 1 hour later, she was starting to show a late receptive profile. So in the transition between receptivity and post-receptivity. Now, since we have the clue that at 164 hours she was receptive, at 170 she was late receptive, and at 156 she was early receptive, we see that she had a very narrow window of implantation, less than 12 hours. Our recommendation was actually not to transfer at 164 when she had receptivity. Our recommendation was actually to transfer at 156 to 158, so about a little before the window of implantation, because we knew she had a very limited number of hours for the embryo to be transferred to the uterus, to undergo the phases of implantation, and we wanted to give that embryo a little bit more time in order for it to synchronize properly with the receptive phase. Now, just to show you here, again, another way of looking at this, when we talk about our phases of endometrium, these are gradients. They're not just clearly receptive, pre-receptive, late receptive, etc. So maybe if a patient's profile falls here, she's entering the receptive phase, versus if a patient falls here, who she's still pre-receptive one day, but still a bit further away from reaching receptivity. So this is something that we take into consideration, especially for these special cases, to come out with the best scenario. So in this patient case, we did not go with the standard recommendation from our algorithm, because we knew that the embryo had less than 12 hours to implant. So in order to give the embryo a bit more time, we actually recommended transferring right here at 158 hours, right in the transition phase between pre-receptive and receptive phase. So the embryo had a maximal amount of time to synchronize with the receptive endometrium. Now, what happened when she transferred that only euploid embryo left? Well, this resulted in a healthy, full-term baby girl. So this was quite successful for this patient. So one thing to point out here, not only was this patient's window of implantation very narrow, less than 12 hours in duration, but it was also displaced by about 48 hours. So she needed an additional, really, 2 days progesterone in order to achieve a receptive state. Now, without this expertise in clinical support, and I was actually the endometrial specialist on this case, so I spent many months working with the patient and the physician in order to get the best recommendation. What would have happened? Well, if we would have just simply transferred here, maybe at 169 hours towards the end of receptivity, maybe this would have resulted in a failed transfer, or maybe it would have resulted in a biochemical pregnancy loss. And let me show you why. So I shared this study in the previous volume. You can go back and get a little bit more details there. But in 2017, we published a paper, and this was actually one of the upgrades of the ERA test over the years since its first introduction in 2011. We discovered a subsignature that was called the late receptive phase. And this late receptive phase consisted of 22 dysregulated genes and is associated with significantly higher risk for biochemical pregnancy. So if you look here, this was our initial version 1 ERA test, which we had non-receptive, receptive, non-receptive. So the non-receptive is post-receptive and pre-receptive. We then looked at the clinical outcomes of those patient cases who transferred accordingly to version 1 of the ERA test. And we discovered, based upon the clinical outcomes, that there's actually subsignatures. We had the late receptive phase, we had optimal receptivity, which is now simply our receptive phase. And you can see here in optimal receptivity, we had an ongoing pregnancy rate of 80% versus late receptive with only 33.3%, so significantly lower. Same thing with biochemical pregnancy loss. In optimal receptivity, the biochemical pregnancy loss was only 6.6% versus late receptive, which was 50%. So back in 2016 to 2017, we upgraded the ERA test to now include these subsignatures to, again, have the most precise results for patients. So having these 12-hour increment shifts helps us adjust for special observations such as narrow window of implantation, but also helps us avoid poor clinical outcomes such as biochemical pregnancy loss. And ERA is the only endometrial test that offers these 12-hour increment shifts with our recommendations. Now, to add on to the shorter, the window of implantation and narrow window of implantation, we see that the window of implantation is transcriptomically shorter than initially thought. So we had assumed that the window of implantation is open for several days. However, our team looked at over 1,400 patients, and it was determined that the window of implantation on average is about 29 to 36 hours. However, with that said, there are patient cases in which the endometrial receptivity lasts less than 24 hours, and as I showed in the previous case report, less than 12 hours sometimes. So this is very important to take in consideration. Now, how can we support the clinicians performing the ERA test and the clinical staff? Well, we have clinical data review and support for publications. We provide resources to ensure best outcomes and ease of use. And you have access to knowledgeable scientific advisors, nurses, and even in-house IVF physicians. So I'm not sure if everyone is aware of this, but we do have the ability to do a clinical data review of your ERA and PET transfers, and we actually compare it to what we see globally. So you could see here, we look at the first ERA biopsy, what is the percentage receptive versus non-receptive, and we compare your data against the global ERA data that we have. Same thing with second ERA biopsy. But then if you provide the clinical outcome, we're able to provide your clinical outcome with ERA versus the global clinical outcome with ERA. If you're interested in this, you can reach out to your local team, and we would be happy to help you get this data. But I think it's very important because then you're able to assess how ERA is performing in your hands, and if there's any room for improvement or ways of optimizing your results even further. Another report we offer is an in-depth ERA result report. And you can see here, we look at results by doctor in your clinic, and even we look at the timing. Now, I want to mention a point about the timing. Just a story about that is we had one clinic that was performing biopsy a little bit earlier, so about 108 hours of progesterone exposure, which is fine. We're still able to get a valid result. However, the issue is you're at much higher risk for having to repeat a biopsy. So we told the clinic, okay, instead of biopsying at 108 hours, if you just add an additional 12 hours of progesterone at biopsy, your pre-receptive 2-day rate is going to decrease, which means your request for second biopsies is going to decrease. So yes, we can get a result at 108 eventually. You just might have to do more repeat cycles. So these are some of the things that we can discover when we look at your clinical data. Again, if you're interested in that, we'd be happy to pull your data and provide you with these full reports. And then, as I mentioned, we're also here to support you. If you have any publications you would like to submit in journals or maybe abstracts for conferences, our team, both locally and our global team, is happy to review that for you. In fact, we just had a recent case report published in Japan in which our APAC team helped with reviewing of the data and reviewing of the final write-up of the paper. Provide resources to ensure best outcomes and ease of use. So Vikram mentioned our ERA Insight Hub. We're very proud of this because we've filled it with a lot of resources that we believe will help clinics and patients on their journey with ERA. So the website, the direct website is here at the top, and I'll review of other what we have to offer on the ERA Insight Hub next. One resource we provide is our Personalized Embryo Transfer Calculator, or PET calculator. Now, our PET calculator is it's very helpful, and when I show clinics this, they're quite excited because instead of performing the calculation in your head or potentially not getting the calculated number of hours correct, it's a bit stressful. So we've taken that stress out of it, and we have the Personalized Embryo Transfer Calculator. This can be found on the ERA Insight Hub, but it's very easy. And what you do, you first select the cycle type. Are you performing HRT cycle or natural cycle? Then you select the embryo that stage of embryo you're transferring. Are you transferring blastocyst transfer or a day 3 cleavage embryo? We also have an option in case you're calculating for the biopsy cycle. So again, we recommend 120 hours at HRT or 168 hours in a natural cycle for biopsy. And then you're going to indicate the number of hours after starting progesterone in which the ERA report recommends transfer of a blastocyst. So I selected here hours from the ERA report, and I put in as example 144 hours. So that would be that the patient is a pre-receptive 1 day, let's say. And then you select which date you want to use in order to calculate the progesterone exposure. And my recommendation is always to put in your desired transfer date and time, since the scheduling at the clinic is always a bit more stringent than maybe when the patient can start progesterone. So in this example, I put June 27 at 9 a.m. is when I would like to perform the patient's transfer. You press calculate. So based upon blastocyst transfer and an HRT cycle at 144 hours with desired transfer date and time, June 27th at 9 a.m., our calculator informs us that the patient should start progesterone on June 21st at 9 a.m. So again, this takes, it's a bit of a double check to make sure that we're properly timing the patient's transfer according to her ERA results. Now, we have seen mistakes performed in the clinic where maybe we say 144 hours and they transfer at 130 hours because there was a miscalculation. Again, I highly recommend using the PET calculator to make sure we're really getting the correct timing at transfer. We also have an ERA clinical checklist. This was a form that was designed by our in-house IVF nurse. So on top of having in-house IVF physicians consult, we do have in-house IVF nurses available too. Our head nurse, Lauren, she does trainings. She also does patient webinars, which I will explain in a few slides from now. And she's a wealth of knowledge when it comes to understanding ERA from a patient perspective. Now, this ERA clinical checklist can be used by both physicians and patients. And the point is that we want to make sure we're replicating the cycle and the endometrial conditions from the mock to the transfer. And this side by side, so you can see here, you enter which, this is going to be for the ERA mock cycle, and then this is going to be for the personalized embryo transfer cycle. Everything should match accordingly. So we want the same, we want to make sure we're controlling for endogenous progesterone. We want to make sure the timing is correct based upon the report. We want to make sure that progesterone type and dosage is the same between the cycles. So this is just a really great additional tool to make sure that we're replicating it so we get optimal outcomes for our patients. And then you have access to knowledgeable scientific advisors, in-house IVF nurses, and physicians worldwide. And these videos are some of the videos from our scientific advisors. So here we have representation from Danny in the UK, Lauren in the US, Alyssa from Canada, and Viviane from Japan and Australia. And we have many more videos to come, but they talk about some of the important protocol compliance features of ERA. For example, why is it necessary to replicate cycle protocol in endometrial conditions? The importance of properly completing the ERA test requisition form. This is key. If we find any errors, we want to make sure we address them. So again, we're getting the best results for the patients. So these videos can be found on our ERA Insight Hub also. And then you also have access to webinars. So our current webinar series, Why ERA, the webinar series we held last year about protocol compliance that Vikram mentioned in the start of today's webinar. We have other webinars performed globally. And then also our Academy Studios. This includes interviews and conversations with top IVF doctors from around the world. So again, our ERA Insight Hub provides resources to ensure proper protocol compliance and optimal results, but also news pertaining to ERA. We have an ERA in Focus, which gives you the most up-to-date studies pertaining to ERA. So right now we're featuring the randomized controlled trial. You see we even have an interview between the first author and the head of our endometrial program, Maria Ruiz, who is a complete wealth of knowledge when it comes to endometrial health and testing. And then the ERA in Practice and other resources that can help improve the usage of ERA. Now, conclusions here. Successful implantation is a rate-limiting step to successful pregnancy in both human reproduction, IVF, and largely hinges on optimal embryo and endometrium. RIF affects about 10% of the population, and patients affected by RIF are prone to drop out of IVF treatment and are eager to address the cause of implantation failure. ESHRE good practice recommendations indicate that endometrial function tests, such as ERA, can be considered in cases of RIF. The ERA test was the first commercially available test addressing RIF of endometrial origin and the only endometrial receptivity test supported by a randomized controlled trial. ERA is backed by unmatched clinical support and experts in endometrial health. And both clinics and patients can benefit from the support offered by the ERA test. So special patient window of implantation observations, such as narrow windows, patient counseling and education webinars. So again, if you refer to the ERA Insight Hub, there's an area for patients to sign up for pre and post endometrial testing webinars with our IVF nurse. So we do have in-house experts who are able to consult directly with patients with their questions. We simply do not send them back to the physician. We take on the responsibility of educating patients if you so choose. Review of data to help optimize the test further at your clinic. So is there an area that we can improve on? As I mentioned, are we performing biopsy at 108 and we can improve our receptivity rate or at least decrease our number of cases in which a second biopsy need to be performed? And then the tools and resources for ease of use and ensure accuracy and maximal results. And those are some of the tools that I shared with you from the ERA Insight Hub. So with that, I want to thank you for your time today. And I think we can welcome Vikram back and we can start our Q&A session.
Thank you very much, Stephanie. I'm sure the session has been quite engaging. We have quite a few questions here. So I'll just begin. Thank you very much for your effort once again, Tiffany. I'll just begin with the questions. Give me a sec. Yeah. Uh, the first question is, what can be the reason for change in a window of implantation in a patient who had no surgical intervention or change in BMI?
Yeah, in those cases, we wouldn't assume the transcriptomic signature would change necessarily. In fact, we've seen that we've tested up to 40 months that the ERI results are completely reproducible. And then we've had multiple cases of patients coming back where we found the results are reproducible in clinical cases year after year. So I would say if the endometrial conditions are the similar, the patient hasn't had any uh, endometrial interventions or surgeries, and you're replicating the protocol and her BMI has stayed stable, then we would expect that the window of implantation, the transcriptomic signature would be consistent from one month or 1 year to the next. It's only in those cases where we've seen extreme change in BMI or change into uterine conditions, or again, make sure that you're replicating the cycle protocol exactly, then we would expect consistency.
Thanks, Stephanie. I'm going to the next question. Is ERA indicated in patients with RPL?
Yeah, so when it comes to recurrent pregnancy loss, these patients would be better suited for microbiome testing for Emma and Alice because we know that pathogenic bacteria has been associated with recurrent pregnancy loss and adverse obstetric outcomes. Now, I mentioned that ERA, we have one phase, the late receptive phase, that has been associated with increased risk of biochemical pregnancy loss. So, if a patient has had multiple biochemical pregnancy loss, ERA could be useful. But if it's a recurrent pregnancy loss, what we would think is RPL um, after a few weeks after implantation, ERA would not be the first line of defense there because ERA, we're focusing on properly synchronizing the embryo for a good implantation. So biochemical pregnancy loss, yes, for ERA. If it's recurrent pregnancy loss after implantation, then I would recommend Emma and Alice for that.
Thanks, Stephanie. Uh, well, another question is, can we do ERA in natural cycle without measuring the LH surge and giving an HCG trigger? Can we do ERA in natural cycle without measuring the LH surge and triggering with HCG? And but at the same time, we'll be measuring only the endogenous progesterone, like in HRT cycle.
So you can technically, if you observe, uh, uh, you know, signs of ovulation with ultrasound. Though this is a bit tricky because you would have to bring the patient in to see follicular rupture and to confirm that. So if you are doing a natural cycle, the recommendation is either to measure the LH surge. Now, you could measure the LH, have the patient measure LH surge at home using urine strips, and you want to see a negative, positive, negative pattern to determine the day of the LH surge. But my recommendation with natural cycle is going to be HCG trigger because this is going to give you the most control over the patient's cycle. So yes, technically you can do it without measuring LH surge, but then you're relying on ultrasound to observe follicular rupture to calculate days of ovulation. Um, I would personally just either do HCG trigger, that would be my number one, or measure LH surge. But again, if it's not possible for the patient to come in for to test serum LH, they could use urine testing strips at home.
Okay, thank you, Tiffany. Tiffany, we have one question, one more here. It says, my patient's progesterone value on day 2 is more than 1.5 nanogram, even after down regulation. Can I proceed with that test?
So I'm guessing this means day two of their cycle. Um, we have seen some patients who have elevated endogenous progesterone levels throughout their menstrual cycle. So even in the first half, in the proliferative phase of this cycle. And in these patients, unfortunately, we cannot ensure the reproducibility of the results because we need to measure, you know, really like when that first hit of progesterone starts in order to start, like I said, the clock um, of when to be able to transfer based upon progesterone exposure time. So for those patients, it is very difficult to ensure reproducibility. They can certainly try the ERA test, but you know we can ensure the reproducibility with going in with a higher endogenous progesterone level. It happens. I've seen it. I've seen it several times where we have these persistently high endogenous progesterone. And actually, in fact, if this physician would like me to reach out to them, I can give them more information and a little bit, our experience with that.
I think the second part of this question echoes what you suggested. The second part of the same question is, I have tried down regulation for 3 months, still value is 1.5. Is then is p value less than 1 must for error? Suggest please.
Yeah,
P
we
value is
use
P4 value, if I'm right.
yes, yes, yes. So we have the cutoff as endogenous progesterone less than 1 nanogram per mil because we've seen that even small levels of progesterone, around 1.5 mil to 2 mil, can initiate the secretory phase changes in the endometrium. So these small concentrations of endogenous progesterone have the effect of um, affecting the endometrium. So for that matter, that's why we can ensure the reproducibility. But again, I think the best case would be if you want to, I can review it along with our endometrial team in headquarters, and we can see if there's any solution. I think that's one of the benefit of having, as I said, we work with over 3,000 clinics worldwide. More than 200,000 women have undergone the ERA. It gives us a lot of knowledge, and we see a lot of similar cases and have experience in which we can offer some guidance. So please, Vikram, if you can share after the information and we can reach out and see what we can do.
Thank you, Tiffany. I am sure the message has been heard by the doctor, and I would request my Chennai colleague who is in the call to get in touch with Dr. Jansi and get the needful done so that the communication is sent to Tiffany directly along with the reports and TRF forms and the history of the doctor so that Tiffany can take it forward and get back to the doctor. I think my message has been loud and clear to my colleague in Chennai. Then we have another question. Are there specific patient subgroups, for example, RIF, PCOS, older age, that benefit more significantly from ERA guided personalized embryo transfer?
Yeah, we've seen that there are some patient subgroups who have an increased displacement of window implantation, and this includes women with a BMI over than 30. So once the BMI is over 30, we've seen a significant increase in displaced window implantation. We've also seen women with atrophic endometrium, so less than 6 millimeters. These women too have a much higher risk of having a displaced window of implantation at the standard time. Women with adenomyosis. Um, we are starting to see women studying more women with advanced maternal age. In the RCT I shared, this was specifically addressing women with AMA, and we never understood, was it just because women with AMA, they've been undergoing IVF much longer or attempting pregnancy because and having failure, and they are recurrent implantation failures. So it's just a reflection of this, or is it because there's some endometrial aging factor that's going on that's causing the displacement? So this we're studying further, but it looks like there's a trend for older women to have more displaced window implantation. So yes, there's definitely subgroups of women who are at increased risk of having a displacement. So as I said, um, women with a BMI over 30, patients with adenomyosis, patients with atrophic endometrium, and potentially advanced maternal age patients.
Thanks a lot, Tiffany. Couple of more coming your way. What kind of training or support is available to clinicians and embryologists to interpret and act on error results effectively?
Yeah, so we offer full training when it comes to our endometrial test. Um, and we can customize based upon your clinic's needs or wants. We have local scientific advisors in every region. Um, we have, like I said, endometrial specialists, genetic counselors. In our headquarters, we have an in-house physician. We have um, Maria Ruiz, who is our endometrial director, and who, as I mentioned, is a complete wealth of knowledge when it comes to ERA and Emma and Alice. You have myself. If requested, I come into meetings. I've done several in India actually, and so we can go through, look at your data, um, pinpoint some areas that we may want to focus on, and then we can provide training for physicians, medical assistants, nurses, um, basically anyone in your clinic. I've done some trainings where I've had our IVF nurse do IVF nurse training with the nurses in the clinic. So based upon your needs, we can customize it and get all the training. We can focus on protocol. We can focus on scientific evidence behind the test. So essentially anything.
Thanks, Stephanie. I would like to add here that Dr. Bratati, who is our local scientific advisor, she's also in touch. Doctors get in touch with her if they have any issues in interpreting the outcome of error. So she will be the naturally the first point of contact. But as Stephanie has said, that we have multiple levels, right? So we are all there for the doctors and the patients. We are here to serve them, and don't hesitate to get in touch with any of us. Well, a very interesting question. Could ERA be combined with other omics based diagnostics, for example, microbiome, immunology, to create a more holistic profile of endometrial health?
Yeah, so right now we obviously offer ERA with Emma and Alice, and we call that our endometrio test. We say trio because it includes ERA, Emma, and then Alice. So Alice looks specifically for those bacteria associated with chronic endometritis. And here you get a 360 view of endometrial health. As I said, when it comes to endometrium and optimal endometrium, our two major factors are receptivity and microbial health. So we do offer combined testing here. So with a single endometrial biopsy, we'll look at receptivity and we look at complete microbial profile. So this way, if there is the endometrium isn't in the best microbial health, we'll provide a direct recommendation for antimicrobial therapy based upon the bacterial species that's present. And then if the patient is not receptive, at the same time, we'll offer the receptivity results on when to plan the transfer. So you can do both of these tests at the same time, get the results within the same site and at the same time in order to treat both simultaneously and transfer.
Thanks, Stephanie. We are over with the questions, but I would like to request all the doctors to stay with us for a minute. This is a question from me, Tiffany.
Mhm.
Uh, is it advisable after we have got so much of evidence of dysbiotic microflora in the endometrium and maybe in cervix lining and all that? Is it advisable nowadays to only bank upon ERA for window of implantation displacement, or is it wise to go ahead with endometrio, which involves Emma and Alice in addition to ERA, which not only will give a holistic view of the endometrial health, but at the same time will save one precious cycle towards the journey to attain motherhood. So, what's your take on that? There's a question from me.
So I actually think that Emma and Alice is more widely applicable. So Emma and Alice is recommended for patients with recurrent implantation failure, but also patients for recurrent pregnancy loss. And I think we're going to see an expansion of that because you know, where humans are made up of more bacterial cells than we are of human cells. So the bacteria within our body actually guides our status of health and our status of disease. And that includes even our reproductive outcomes. So the endometrium, we have a very unique profile of bacteria that inhabit that environment. And we've already seen that if we have pathogenic bacteria present, this can lead to failed implantation, it can lead to pregnancy loss, and it can lead to obstetric outcomes such as preterm birth. So optimizing the bacteria is very important. And this bacteria, it's affected by many things. So it's not like it stays consistent for all your life. So where we see that the ERA results are quite reproducible even year after year, the microbiome can shift to factors such as your diet, general hygiene, sexual intercourse, use of antibiotics. That's a really big one. So you might take antibiotics for maybe a sinus infection in your head, but that antibiotics is going to be exposed to other microbiomes in your body and affect the bacteria then there. So I think when we're talking about IVF, and you'll see, you may remember from my introduction, my PhD thesis was on how to optimize IVF, and I was focusing on embryo aneuploidy and endometrial receptivity. But I think the point here is to always keep getting better and to make things more efficient for patients. So testing for the two main endometrial factors can certainly be beneficial, particularly because we have overlapping indicated populations when it comes to ERA, Emma, and Alice, which is recurrent implantation failure. So if a patient has had recurrent implantation failure, um, ERA can help, and then adding on EMA and ALICE even the better, because then we're addressing those two big main factors that can lend to repeated implantation failures.
Thank you so much, Tiffany, for this very important session and sharing of knowledge with the doctors here in India. Thank you very much for sparing your time. Not today. As usual, you're always ready to help us out. Thank you again. And I would like to thank the doctors for joining us today. And the message goes like this: doctors, ERA is a step basically forward in personalizing IVF and improving outcomes. If you trust us at Igenomics, we truly appreciate your dedication into patient care and look forward for continued collaboration with your clinics and with you. And we are striving for bringing new updates, new research for the betterment of your patients. Like after ERA, we came with Emma, we came with Alice. We are still working on in that direction. Our R&D is working. So impose your faith and trust on us. And thank you very much for all the support, and thank you very much for your time this evening. Thank you, Tiffany. Thanks, doctors. Good evening.